Okay, so today for this lecture, we're going to examine several antibiotics that are useful for the treatment of pneumonia. Of course, there are several bacterial causes of pneumonia, many of which are listed here. This was referenced from Dr. Richard's course materials, so I'm sure you'll find them to be nicely complementary. Just to review, we can loosely group the antibiotics that we're going to talk about into three main drug classes. And so we can look at as a group cell wall inhibitors, which include the beta-lactams, and then the co-administration of the beta-lactamase inhibitors, such as clavulanic acid. Glycopeptides, such as vancomycin, are also cell wall inhibitors, although through a slightly different mechanism. Drugs that inhibit protein synthesis are very numerous, many of which are listed here. I'm pretty sure you will recognize almost all of them. There's a few that we're going to talk about in this lecture that are new. And of course, there's a handful of drugs that are going to be affecting nucleic acid synthesis, particularly your sulfonamides, your fluoroquinolones, as well as your trimethoprim. And so, looking at pneumonia, I think we're going to start with treatment of S. pneumoniae. And this pathogen is really kind of responsible for the bulk of the community-acquired pneumonias that you can see out in the clinic. Several different methods are available for the treatment of this pathogen. From the outpatient perspective, you can look at patients that are essentially previously healthy and have not taken any antimicrobials within the previous 3 months or so. They can be given macrolide antibiotic, 3 of which are listed there, doxycycline, as well as a fluoroquinolone. In the outpatient context, in the presence of comorbidities, however, particularly patients with chronic heart, lung, liver, or renal disease, the best agents are fluoroquinolones or beta-lactams plus macrolides. For more sick patients, particularly inpatient non-ICU, the main drugs are fluoroquinolone or beta-lactams. And then for patients that are in the ICU, of course, we're looking at a little bit more aggressive therapy, beta-lactam plus macrolide, beta-lactam plus fluoroquinolone, or fluoroquinolone plus monobactam, specifically aztreonam. There is concern that widespread use of fluoroquinolone in patients will promote the development of fluoroquinolone resistance, particularly among respiratory pathogens. But you just have to just kind of keep an eye on kind of the local treatment options that exist, but that is kind of a valid concern. Both the macrolides and the fluoroquinolones as a group can cause prolonged QT intervals, which on the EKG will look like torsade de pointe. So that's one thing to keep in mind, particularly patients that have these comorbidities, as well as some of these particularly sicker patients that are in the ICU. S. pneumoniae can also produce meningitis, of course, and so we had talked about meningitis previously, but I think this is a good time to review it because it's kind of the same bug. So the first line therapy typically for meningitis is vancomycin plus cephalosporin. They're all alternative agents, 3 of which are listed there. Remember, of course, vancomycin is also a cell wall inhibitor. When we talk about macrolides, we're talking about something like chloramphenicol, which could be a protein synthesis inhibitor. And then fluoroquinolones, of course, are your nucleic acid synthesis inhibitors. The older fluoroquinolones have really kind of lacked sufficient activity against S. pneumoniae, and so you don't really see them used in pneumococcal meningitis. Treatment options for nocardia, really kind of the first line is Bactrim or Septra, which is trimethoprim sulfamethoxazole, and it's really kind of the only drug that works for this particular infection. And so one thing to do is to make sure the patient is not allergic to sulfur containing drugs, because obviously sulfamethoxazide has a sulfur moiety within the chemistry. For Coxiella burnetii, the first line therapy is doxycycline. There are alternative agents that, of course, you can use if the patient doesn't respond or is allergic to doxycycline. Mycoplasma pneumoniae, typically you're looking at either macrolides or doxycycline or fluoroquinolones. We can't use cell wall inhibitors because, remember, mycoplasma doesn't have a cell wall. So please don't use those drugs in this context. Uh, Chlamydophila pneumoniae, typically given first-line therapy macrolides. Other agents that can be used are listed there. Treatment of Camelidophylla pistici. First-line therapy is doxycycline or tetracycline, and then other agents, of course, are listed there. We'll talk about rifampin, of course. The mechanism of action of rifampin is going to be coming in the next slide or two. So we've talked about several different kind of random bugs that we associate with pneumonia, and I really just wanted to give you this information. This is kind of the current thinking as to what's kind of first line, second line therapy for these drugs. I think it's kind of a good thing to have at least your exposure to. I don't know if it's necessarily high yield because some of those bugs are relatively rare, but TB is relatively high yield. It's a obviously a dangerous pathogen. Of course, we're looking at Mycobacterium tuberculosis, the bacteria that produces TB. Of course, we always remember the acronym RIPE, and that's basically to remind us of the drug combination. So rifampin, isoniazid, pyrinzinide, and ethambutol. These are basically the four drugs that are used in combination to treat active TB. And so rifampin and isoniazid are kind of the most active, and so even if these two drugs are the only drugs that are given, you need them for 9 months. So it's a long treatment outcome. The addition of pyrazanamide can reduce therapy from 9 months down to 6 months, and then the addition of ethambutol is warranted if the isolate has any type of resistance to one of the other 3 drugs that are listed up here. So all 4 of these drugs have the potential to produce drug-drug interactions, and all 4 have the potential to produce hepatotoxicity, and that risk increases with age, of course, and so patients that are older than 30, 35 years of age, you're really going to have to monitor a liver function test quite regularly in these individuals. Patients with comorbidity, such as HIV positivity, pregnant women, patients with alcohol or substance abuse, hepatitis, history of liver disease, fatty liver disease, and so forth, would need probably more aggressive monitoring of liver function tests to make sure that they can handle these 4 drugs. In terms of how these drugs work, isoniazid inhibits synthesis of mycolic acid, and this is really kind of the main fundamental building block in the cell wall that's specific to Mycobacterium species. Rifampin binds to the RNA polymerase, of course, and that's going to inhibit mRNA synthesis. Pyrazanamide is actually taken up by macrophages, and it actually exerts its activity in the acidic environment of the lysosomes, and so it's kind of like a Trojan horse. The exact mechanism isn't exactly known, but that's basically how we think it's working. It actually acts like a Trojan horse, and then as these macrophages interact with mycobacteria, it has its effect. Ethambutol inhibits a specific enzyme, mycobacterial transferase, and that, of course, is of course specific to Mycobacterium species. And so this is how these 4 drugs work. The side effects, basically, to some extent, liver toxicity for all of them. Rifampin also produces orange-colored body fluids, and so that's kind of a favorite board question. How do you know the patient's on a specific drug? Well, their urine or their sweat or whatever is orange colored, and so that's a key red flag that it's rifampin. Rifampin also is cleared through the kidneys, and so you can also see some renal toxicity developing there. Pyrazanidine, you can see increased urination, nausea, and vomiting, and so forth. Ethambutol has the added benefit of ocular toxicity, and so patients can see or experience changes in vision. Streptomycin, which may be warranted in certain contexts, has both renal and ototoxicity associated with it as well. And so these are kind of the second line agents, and so that's why we kind of talked about streptomycin previously. It can actually be used in place of ethambutol in certain instances, and then other drugs that have demonstrated activity against TB are listed here.